Hi, everyone. This is another video walkthrough of one of our cases. This is one of our free cases. This involves a 59-year-old male who was found at home in the garden by his wife with slurred speech. He was noted to have right face, arm, and leg weakness. EMS arrived to find the patient's blood pressure 175/90 in the field, and they checked a fingerstick blood sugar, which was 122. On arrival to the emergency department, triage notes that he has acute onset of right-sided weakness. Of note, we don't know the time duration of the weakness at this point in time, otherwise known as the last seen well time. He has slurred speech. His wife is en route to the emergency department, and the patient is transferred directly to the resuscitation bay. So with that, we begin the case. Of course, as with most of our patients, we want to get them attached to the monitor and get an initial set of vital signs to start. What we can see is that his heart rate is 85, his blood pressure is hypertensive at 175/83, and his temperature, oxygen saturation, and respirations are unremarkable. The other thing we want to do, noting that he has an irregular rhythm on the monitor, is obtain an ECG. The ECG is done, and what we note is that he is in an irregular rhythm consistent with atrial fibrillation. So it'll be important for us to know whether this is new or old, given his acute onset of weakness, that at this point in time is concerning for an acute stroke. Taking a quick bit of history, he was found in the garden by his wife. He has slurred speech, right-sided weakness. That would be concerning for a left-sided MCA stroke. Paramedics state that he had no signs of trauma on scene, which is very important because of the therapeutic options available to us. He was found lying on the ground with near complete right-sided face, arm, and leg weakness. He was hypertensive en route. They could not establish IV access. Importantly, he was protecting his airway in the field without need for intubation. Looking at his past medical history, we note that he does have a history of hypertension, hyperlipidemia, but he does not have any stated history of atrial fibrillation, and on his medication list, he's not on any anticoagulation therapy that would relate to him potentially being in chronic atrial fibrillation or having a history of paroxysmal atrial fibrillation. He has no known drug allergies. He's a former smoker. In terms of his initial evaluation, what we'd want to do is assess whether there's any signs of systemic illness, any history of palpitations, and certainly ask any history of neurologic symptoms leading up to this. But unfortunately, the patient has a receptive and expressive aphasia on arrival, and so we are concerned that we can't really get any further history at this point, so let's move to the physical exam. Because he has a depressed GCS and was noted to be somnolent, we want to first make sure that airway, breathing, and circulation are intact. And right now, it appears that his airway is patent. He's not showing any signs of obstruction and does not have any indication for emergent intubation at this point in time. From a cardiac exam, we note that he's irregularly irregular. He's got clear lungs bilaterally. And from a neurologic standpoint, we note that he is somnolent, unable to follow commands. He has 2 out of 5 strength, meaning he is unable to resist against gravity. And he has it to the right face and right arm. He has 3 out of 5 strength, so therefore barely able to lift against gravity off of the bed in the right leg, and he has an aphasia. He has no blink to visual threat on the right. So stabilization, we want to first establish IV access, which now we've done thanks to our expert nurses. His vital signs otherwise are okay at this point. We don't need any oxygen, fluids, and we don't need to intubate him at this point in time. Right now, my differential would be primarily in the neurologic category. And so as I scroll down, there's a variety of things. Obviously, ischemic stroke, where there's an acute occlusion to a blood vessel, would be my main concern because that could be treated with thrombolysis. However, it is possible that migraines, certain severe types of migraines, can lead to hemiparetic presentations. He's a little bit on the older side where I would not have that obviously as my leading diagnosis, and that would be more a diagnosis of exclusion. The other possibility is that he has a hemorrhagic stroke or some other form of intraparenchymal hemorrhage, such as subdural or AVM or something like that. And so I'd want to keep those on the differential as well. Now, as we get into bedside testing. Obviously, the most important next step is to get this patient to the CT scanner. However, before we do that, I would want to do a quick bedside check. Even though he had a finger stick blood sugar in the field, I would want to confirm that it was indeed correct and that he is not hypoglycemic. Hypoglycemia can present with acute hemiparesis and be a stroke mimic, so we do want to make sure that we're not having any issues with that. In addition, I would want to send some basic stat labs, including a chem panel, because acute hyponatremia can also cause unilateral weakness, although it is uncommon. And I'd want to send a type-in screen in case we undergo thrombolysis, a CBC, coagulation panel, and other testing that we could obtain if we wanted to would be a urinalysis, not really critical at this point. I don't think it's a UTI, but getting a baseline urine, if able, is reasonable. And then any other extended labs here would not necessarily be indicated at this time. So let's go ahead and get a CT scan ordered. So we go down here, CT head. Now, why not an MRI or other diagnostic imaging? CT is by far the fastest modality, and by the current stroke guidelines, obtaining a non-contrast head CT is the quickest way to ensure that there is no evidence of a tumor or intraparenchymal hemorrhage that would otherwise contraindicate thrombolysis therapy. So we perform that. And now, as we scroll through his labs are relatively unremarkable, as we might expect, and his CT of the head does not demonstrate any masses, any evidence of hemorrhage. So now we need to figure out what the time of onset was and really confirm that. So now that his wife has arrived to the emergency department, we can talk to her. And she states that she last saw him well 30 minutes before finding him. That was about 1 hour ago now. So his last seen well time is approximately an hour. He's within the 3 to 3.5 hour window for thrombolysis. He has no history of brain tumor, stroke, recent surgery, or procedures, and he's not on any blood thinners. Those are all very important in terms of determining whether he is a candidate for thrombolysis. And she does indeed consent to definitive treatment. Normally, we could progress to immediately thrombolysing him. However, at this point, we could consult neurology if we wanted to. So the neurologist is coming in to see the patient. They're about 20 minutes out, but they recommend giving definitive treatment based on the exam. So at this point in time, we can go back to our interventions. And in terms of medications, we would want to give TPA. And so we administer TPA in bolus. And typically TPA will take a while to start taking effect, but in the world of virtual simulation, we can go back and kind of accelerate time a little bit and see if there's any change in his neurologic exam. And the weakness is all on the right side, as the nurse is saying. However, on the exam, now he is awake. He is able at least to follow one-step commands, and he has slightly improved strength in the right face and arm, as well as in the right leg, showing a slight improvement after thrombolytic therapy, which is very reassuring. Now, we will want to closely monitor him, in particular his blood pressure. At a blood pressure of 185 over 90 to 100, that would be when we would want to give him some degree of antihypertensive therapy in order to bring it down, in order to have him qualify for thrombolysis. Even though his blood pressure is significantly elevated, it is tricky in the case of an acute ischemic stroke, where you want some degree of a pressure head in order to perfuse the ischemic penumbra around the stroke territory. And so empirically treating his hypertensive reading on arrival would not be necessary in the fact that it could extend his ischemic insult. And so while he is right up against the threshold for where we would think thrombolysis is safe, at this point in time, I'm going to choose not to treat him with any antihypertensive medications so that we can maintain his perfusion pressure. Now that we've administered TPA, I can let neurology know. They agree that the exam is concerning for acute stroke. We've already obtained the stat imaging, and we've already treated the patient. And so at this point in time, we can admit the patient to the ICU. and the diagnosis is ischemic stroke. I will go ahead and hand off the patient. And as usual with our full code cases, I get a rundown of all of the actions that I've done in each of the sections, as well as a detailed discussion covering all of the essential diagnostic and therapeutic content as it relates to this particular presentation of acute ischemic stroke. In addition, in this debrief, we talk specifically about the contraindications to TPA administration, as the rate of causing life-threatening hemorrhagic bleed is somewhere in the 1% range. And so we do have to have an informed consent discussion with either the patient or their next of kin family member so that we can obtain informed consent prior to performing thrombolysis. We also provided the relative contraindications for thrombolysis and other exclusionary criteria, including age greater than 80, anticoagulation use, severe stroke, and history of prior stroke and diabetes. Again, these are relative exclusion criteria, and so they are criteria that we would use if the patient is outside of the 3-hour window, but is a potential candidate for thrombolysis. With all cases, we provide you with the essential references and further reading. And that is all for this case. So we'll see you next time.